in a tough economic time right now, as we all know, and most of us, or most of the doctors that I've spoken to as I lecture around the country, in fact around the world, are all complaining of being slower than they would like to be, and that makes sense in this economy. So what I want to focus on is how we can eliminate that. So how can we flourish in a down economy? Number one, we've got to keep our regular patients coming in on a regular basis. We've got to get new patients. We've got to make sure we minimize broken or canceled appointments. And most importantly, we need to maximize production during the time that we are working. And we can do that most effectively if we have a bigger bag of tricks, a wider array of procedures that we can easily and competently perform. Instead of referring stuff to specialists or ignoring it completely, let's start thinking about doing it ourselves, because it's the work that we're either ignoring or referring out that will significantly increase your production, not the work you're already doing. Nobody got rich in their practice by doing a faster class 1. We maximize things by doing stuff that we're currently not doing. In 2008, we were fortunate enough to have the best year we've ever had in over 40 years of practice. And I only worked a total of 116 days. That's 7 hours a day, 3 days a week, Monday, Tuesday, and Wednesday, on the weeks that I was there. And I take a lot of time off, both for personal vacation time and also to lecture. Almost 50% of my personal production was perio and oral surgery, laser-assisted extractions and such. And I'm an average dentist at best. If I can do it, so can you. So let's talk about the procedures that are going to yield the greatest return on investment. One of these that isn't up here is one that we're not going to touch today, but I want to touch on today in terms of the seminar, but I wanted to mention it if you're not doing it, and that's incisal edges, class 6 incisal edge restorations. You can easily do 6 of these in a half-hour appointment, even with the old gold handpiece, and with the turbo handpiece. If you have one, and if you don't, you certainly should get one because it cuts 3 times faster. You can knock these out in 15 or 20 minutes and literally make a month's laser payment just by doing these procedures. So let's focus on the things we're going to talk about today: laser-assisted extractions of bone grafts, biopsies and excision of lesions, and perio. I can't stress how much this will add to your practice and how easy and stressless it is to do. Let's first talk about laser-assisted tooth extraction and bone grafts. What we're going to do is use a laser as an osteotome. If we have multi-rooted teeth, we're going to make them single-rooted teeth first before we try to extract them. We're going to angle the tip towards the root. And most important of all, we want to be very, very patient. Don't force the issue. Elevate gently, and if it's not loose, virtually loose enough to pull out with your fingers or with a gentle flip of an elevator, or very lightly grabbing and teasing it out with a pair of forceps, keep lasing. If you do this, you literally will never break a root tip and will never break off any thin buccal plate of bone. Following the extraction, we want to remove granulation tissue and then decontaminate the surface. If there is insufficient bleeding, we're then going to decorticate the bone. What we're going to do is turn the laser on to a dentin cutting setting and lightly run it over the inside of the bone inside the socket until we ablate away enough of the cortical plate in an area to reestablish bleeding. And then finally, we're going to deepithelialize outer tissue. Now, when we do this, I'm going to show you a little video now in a moment. And this video is an interesting case. This is a patient that had I had done 6 anterior crowns on many years ago, and number 10 fractured off at the gingival margin. It also had a fistula because there probably was a crack for some time before it actually broke off. Patient came in frantic because in 1 week they were leaving for a business trip cross country. I'm in the East Coast in Laurel, Maryland. She had a business trip a week later in San Francisco. So what we were going to do ultimately after giving her the options was ultimately do an implant. But of course we couldn't do that immediately, and especially in the presence of infection, we want to err on the side of conservatism. So what we did was take an impression. We brought her back a week later, literally 3 hours before she got on an airplane for a 5.5-hour flight. And we had a flipper made, and what you're going to see is an edited down version of this extraction. Now when we do these, the neat thing is we can bill 3 separate fees. Between the surgical extraction fee, the bone graft fee, and the guided tissue regeneration fee, you literally will make pretty close to, if not completely, 1 month's laser payment just on this one procedure alone. And guess what? The entire procedure, including putting in a flipper, which incidentally was an additional fee, took 4.5 minutes. From the time I got her numb to the time we were done, it took 4.5 minutes. Now, what you're seeing is an ankylosed root and also a little fistula which will appear at one point or another. What we're doing now is using a Z3, a 14 millimeter Z3 tip to blow down the ligament space between the tooth and the bone to loosen that root. You can go all the way to the apex if you need to. It's really amazing. And when you do this, you maintain that thin plate of buccal bone, which is so critical to getting a good aesthetic result when we are ready to do our implant. Now you can see that it's already loose, but I have nothing to torque that elevator against to grab it, and my fingers are too fat to reach in and grab with my fingers, so we're using an instrument just to plop it out. Now what we're going to do is use a laser to go down into the pocket, and for this we're going to use a dental periodontal setting, about 1.5 watts, 15% air and water. And we're going to very carefully run it up and down and around the entire inside of the socket so that we decontaminate the socket of any infected material and remove any granulation tissue. I'm checking now with a curette to make sure that the granulation tissue is gone. We've also decorticated so that we're starting to reestablish some bleeding. And now we're using a sterile amalgam carrier to place our bone graft material. This is Puros allograft, which is freeze-dried cadaver bone. When you take the course, we'll give you a variety of different bone graft material, some cadaver material and some synthetic, and the pros and cons of each and when to use which one most effectively for your patients. And now we're lightly tapping it down, and now what we're doing is injecting a barrier membrane called Atrazorb. It's a liquid barrier membrane that when we blow water on it, hardens like a hard plastic. Following this, we're going to use our Easy Laze, the bleaching wand from our Easy Laze, and do 30 seconds of low-level laser biostimulation. What this does, for those of you who are not familiar with this technique, is going to stimulate faster healing, reduce the possibility of swelling, and this situation is going to heal actually about 50% faster than it would otherwise. Now this patient, normally what we do when we do these surgeries, the same thing with periodontal surgery, is we give the patient 2 Advil, if they can take them, or 2 Tylenol if they can't take Advil, while they're getting numb. And that's all we give them. That's the only medication we give them, and most of them don't need anything else. Now, we of course will provide them a prescription for Tylenol with codeine or Vicodin or something suitable, but I literally have not had one patient that's ever had to get the prescription filled. They'll be sensitive to touch for a week or so, but virtually no postoperative pain. And the reason for that, the reason patients don't have postoperative pain when we use a laser in any surgical situation, and the reason why I literally do not own a scalpel anymore, even though we do a lot of perio and oral surgery in our practice, is that the laser, by cauterizing the nerve endings, lymphatics, and the blood vessels, stops the release of histamine that occurs in conventional surgery with cold steel, and it's the histamine release that starts the inflammatory cascade that has to occur in a normal situation done conventionally before a wound can heal. With the laser, we go right from wound to healing, and we skip inflammation, and that's the reason patients don't complain of any pain. Now, here's some codes that Biolase provided me. These are 50 percentile codes for these procedures, and it'll give you an idea of what the fees would be for an extraction, a surgical extraction in a 50 percentile situation. I charge considerably more. And as I say, in my situation, between the three procedures, the bone graft, the extraction, and the guided tissue, I make 1 month's laser payment. And you can do the same thing if you choose. Now let's talk about minimally invasive periodontal surgery. This is something that you can start doing tomorrow and should be doing on a regular basis in your practice. When we do minimally invasive periodontal surgery, there are a number of things that we can do. Number one, laser-assisted root plane and curettage. We're going to show you that in a moment. Osteosurgery, bone graft, and guided tissue. Believe it or not, osteosurgery, bone graft, and guided tissue is easier to do than a Class II composite. And I'm not exaggerating. It really is. And you get about 10 times the fee for it. Hard and soft tissue crown lengthening. We're going to explore that in a moment. Lingual and labial frenectomies, gingivoplasties, apicoectomies, biopsies, and other excisions, failing implants, circumferential fibrotomies, exposing teeth for ortho, depigmentation, removal of amalgam tattoos, internal and external resorption, tissue grafts and alloderm grafts, lateral cyst and abscess, and I want to add one more to reverse vestibuloplasty, where if somebody has an extreme gummy smile, we literally, using the laser for incisions, lower the vestibule to reduce the gummy smile. And it's a really neat procedure. It's not difficult to do, and the results are absolutely spectacular. You're going to love this one. In addition to this, none of these procedures, except that reverse vestibuloplasty, which took us close to 2 hours to do today, none of these, on average, take more than an hour. Most of them take a half hour or less. They're easier to do than a typical Class II composite, and you can generate fees of anywhere from a few $100s to a couple of $1,000s in this time frame. So let's talk about what we're going to do that you can start doing tomorrow. For patients with 4 to 6 millimeter pockets with no furcation involvement, we're going to use conventional hygiene, including ultrasonics and hand instruments, and then we're going to follow it up with laser therapy. And then we're going to bring the patient back in 6 to 8 weeks to reevaluate. And what we mean by reevaluating, we're going to reprobe. If there are unresolved pockets at that time, and there may be some, we have to decide on whether we want to redo the laser therapy or lay a little mini flap and evaluate the need for osteosurgery and bone graft, and with a material that we love to use called Gem 21S. If the pocket is truly 4 to 6 millimeters, 9 times out of 10, you're going to resolve it with the technique I'm going to show you in just one visit. But what happens very often is we have a situation where we have deeper pockets than 6 millimeters, but we stop probing when the patient jumped or went ow, and until we get the patient numb and really probe definitively, what looked like a 6 millimeter pocket may end up being a 10 or a 12 or a 14 millimeter pocket when we open it up. And these are the ones that aren't going to resolve without surgery. So our goal is to remove the diseased succular epithelial lining, to kill the bacteria and biofilm, to remove the remaining calculus. The Waterlase, as many of you know, will remove that 20% of the calculus that your hygienist will, on average, leave in every mouth, and that's why you get recurrent pockets, redundant pockets that don't heal, because you didn't get all the junk out of there. The Waterlase, just literally, as you'll see in a little video in a moment, very, very easily will loosen up, and literally you'll see black gobs of calculus bubbling out of the pocket. We also remove the smear layer and get rid of endotoxins on the root, and we lightly etch the root surface with our technique for reattachment. Now what we do, the reason we do that is because a lot of recent research, some of which I'm personally involved in at the University in Vienna, Austria, shows us unequivocally that a laser-etched root surface gives us the best surface for fibroblastic and odontoblastic reattachment. And then we're going to de-epithelialize to prevent reepithelialization and allow reattachment and bone growth. And I'll explain what that is in a moment. And then we're going to biostimulate for faster healing. When we do a minimally invasive periodontal procedure, we are able, most often, to do in one visit what used to take us 2 or 3 or 4 visits with other techniques. The first thing we're going to do is succular debridement. And with succular debridement, we're going to